So hello and welcome. My name is Jason Golbin. I'm the Chief Medical Officer at Catholic Health, and it is my distinct pleasure and honor to be sitting today with Dr. Gary Gecelter, Chief and Chairman of Surgery for both St. Francis Hospital and Catholic Health. Thank you so much for being with us.
I'm very glad to be with you, Jay.
It's great. So today we're just going to have a conversation about what does healthcare look like for Catholic Health, for St. Francis, for surgery in 2023. Before we get started, I think it's important to talk about, to know where we're going, we have to say where we came from. So tell me how you got to be the Chief of Surgery at St. Francis and for Catholic Health.
In the interest of brevity, I had always heard that St. Francis was the best hospital on Long Island. And working in other environments, people were always envious of that reputation. And through curiosity, I came and met with the then president and asked him if I moved my practice, would I get some sort of support? And that's 15 years ago, and I could not have been happier.
That's great, but that doesn't just happen to anybody. I couldn't just come in and say, hey, I want to be, how did you build your practice? Give me your story from where you went to medical school and beyond.
Well, I grew up in South Africa, son of a urologist. I learned how to deal with patients by sitting on my father's knee. He earned respect. He always said to me, this is a vocation. If you think you're going to get rich being a doctor, it's transparently the wrong thing. Just do the right thing always. And he was always an Amerigophile. He loved training in America. He trained in Denver, Colorado. And at the first opportunity I got, I started looking for a job in America, got a job at Stony Brook University. I think you and I met way back when. I think
Yes,
at one point you were my medical student.
1998. I don't want to date anything, but general surgery, third-year rotation.
Yes, and in that environment, I knew that in order to do a good job, patients had to have good outcomes, and their referring doctors had to know that their patients were well cared for.
That's a great lead-in. So one of the things you specialize in is cancer surgery. Certainly surgery between here and here. Tell me what cancer surgery looks like, cancer care looks like at St. Francis, not just at St. Francis, but for the whole system.
The mature model of cancer delivery takes the form of a multidisciplinary tumor board. In other words, we always say that medicine is a science, but decision-making is an art, right? And in order to tailor the exact recipe and planning for each individual patient with a particular disease and their particular condition, as well as their goals of care, you need a lot of people in the room to know what's going on with that patient. So 15 years ago, we started our first multidisciplinary tumor board, which was a gastrointestinal surgical tumor board. And from that, you know, that was the plan. I mean, I was very fortunate to be able to team up with Bumi Marotra, who I worked with, you know, before, and we developed a cancer committee that discusses each patient, each analytic case. So every new case that's diagnosed in our system gets discussed, and it comprises surgeons, gastroenterologists, medical oncologists, radiation oncologists, genetic counselors, and even the clergy. So we always understand where a patient comes from, what their goals of care are, and individualize it. As I say, medicine is a science. The decision-making around that is the art, and we try to practice that art.
So looking at this patient-centric care, it makes me think about specific types of surgery that a specialist such as yourself would do versus a general surgeon. Talk to me a little about specific surgical techniques, specific surgical tools, or specific surgeries that you do that not every surgeon would do.
So the classic example of a complicated operation is esophagectomy. So esophageal cancer is the one disease that requires all hands on deck. The diagnosis is usually made on history of a patient with dysphagia. They then see a gastroenterologist or then endoscopy. He'll do the biopsies. It needs a subspecialist gastroenterologist to use ultrasound, endoscopic ultrasound. It then needs radiology for PET scanning and staging. and then it needs radiation, chemotherapy, and surgery. And the sequence is usually mapped out. And I always tell a patient, if I see a person at the beginning of the diagnosis, and I'll say that as the surgeon, we will not actually interact for 6 months, because now the treatment planning is neoadjuvant chemoradiation. There's an interval of recovery after that before we talk about surgery. And then in surgery, it's really 2 operations. You have a thoracic portion of the operation and an abdominal portion. And in 2005, I started doing this operation laparoscopically, or minimally invasively. Right? So this is not an operation that a regular trained general surgeon after 5 years of training can do. It usually requires thoracic oncology training, minimally invasive surgery, robotics, and it falls into the exact sort of domain of what a multidisciplinary approach to a disease is.
So you talked about the laparoscope. Let's switch and talk about robotic surgery. So you and I have a little bit of history on robotic surgery. When I came over here to Catholic Health, one of the first things that Dr. O had asked was, let's talk about robotic surgery with Dr. Gecelter. And at that time, at least my impression, and I believe that your impression as well, was robotic surgery meant for really deep pelvic work, whether it be prostate work by the urologist or gyn-onc work. But the role of that robot, certainly in my opinion, has expanded tremendously, or the utilization of that robot. Tell me where your brain is on robotic surgery in 2023 and beyond.
When I started doing laparoscopic surgery, my background, in fact, was in surgical gastroenterology. We had to treat esophageal varices endoscopically. We had to stop bleeding peptic ulcers endoscopically. So a surgeon out of the United States, and actually the model is now in the US training of surgeons, is they have to learn how to do endoscopy as well. So if you take that background of the knowledge of the flexible endoscope, and you're a surgeon, and now you start doing laparoscopy, the classic laparoscope is a rigid camera on a Hopkins lens. And I said, why would I want to do that when I can put a flexible scope into a patient? And I was instrumental truly in helping develop flexible laparoscopy. And my workhorse for all of laparoscopy is a 5mm flexible laparoscope that is the size of a big pen.
Okay.
And it flexes, it can look around corners, it can look over tumors, it can look under the pancreas. And that is one thing that the robot cannot do, right? Ironically, the robot has the ability to articulate its instruments, but its camera is rigid. And so I've always said that if I can see it, I can do it. And if you can show me an on-face view of something that I need to work on, then it's enabling technology. What I felt about the robot early on, and still truly feel that today, is that it is, firstly, it's not a robot, right? It is a remote surgical telemanipulator. A robot is something you program, and the computer then executes, right? But if you're sitting at a console, and when you move your fingers, that device is doing it. It's a telemanipulator. The advantage of that is that it's easier to suture with the robot because it has wrist action. And for complicated operations that require suturing, it is definitely enabling. So when we, at that early stage of sort of robotic adoption, I felt that the cost of using robotic instruments did not justify the benefit to the patient. And then what happened is that people started feeling more comfortable sitting at the console. I mean, taking out a gallbladder with a robot is certainly significantly more expensive than doing it laparoscopically. And ironically, when you have a really difficult gallbladder, you have to take out the robot and put in a laparoscope. So the new conversion is not laparoscopic to open, but
robotic to laparoscope.
Yeah. So if you're going to go to a safer modality, why don't you start with that? But there's no question that my group, and I have some unbelievable surgeons who do abdominal wall reconstructions after large abdominal wall hernias, have realized that the robot is very, very beneficial in gaining access to the planes of the abdominal wall, suturing up the different planes. And so there are very specific roles. And also we're looking at the new iterations of the robot. There's the single port platform where everything goes into one incision. And ironically, that does have a flexible camera.
There you go. So they're catching on.
Like anything, I am not a Luddite. I believe in progress. I think that we have to be honest in where our money is best spent.
No, that's a fair thought. Let me change topics and talk a little about our system. We are 6 hospitals and really growing in our systemness. If anything, we like to say we're on the pimply-faced teenager stage, but heading into young adulthood. What does surgery look like at Catholic Health as a health system? How do we unify the way we practice surgery and provide the highest level care, the care that I know you provide here at St. Francis regularly? How do we provide that across our health system?
Well, I think exactly as you said it. I think that we're in our nascent phase. We're learning a lot of lessons. Our overarching philosophy and what drives me every day as it drives you is that we know we're never going to be the biggest, but we are certain we are and will be the best, right? And that's what
one of us had to say that, or else the boss would be upset.
I agree with that, and we live by that, right?
Yeah, I joke, but absolutely.
It's the truth. And so what we did when we started here 15 years ago was we said we have to provide a service, right? So in an academic medical center, there are interns and residents who round on patients, and then the different attendings will come and cherry pick their cases. We didn't have those junior staff, so we as attendings, as surgeons, said every morning, 6 a.m., we will meet in the doctor's lounge and we will run our cases so that everybody knows what's happening, we're up to date in it, and anybody in the hospital who has a question about a case can call any one of us and we'll be able to answer most of the issues related to it. And it's not as well evolved in the other hospitals. There are a lot of private practice surgeons, and Catholic Health has always been a safe harbor for private practice. So we have to be mindful of that, and integrating it is not an easy task. But in answer to your question, where do we see us in the future? If we look at the trajectory of what is happening to doctors in America, I think 20 years ago, 80% of doctors were in private practice, 20% were employed. That is obviously inverted now. Doctors want to be employed. That gives us the ability to create certain standards that engaging those people will have to live by. And I think that's the kind of model we want to be able to convey.
We've been having a great conversation, and I know you don't just work. I mean, we all work a ton, but you must have some downtime. So what does Gary Gecelter's downtime, relaxation time, if you have any, what does that look like? You know, how do you spend your time?
Yeah, about 6 months ago, my youngest daughter moved back from California into my house and then promptly had a baby. So taking care of a grandchild is part of the thing.
Beautiful.
So my wife volunteers.
Is that relaxing?
Yeah, my wife volunteers me for babysitting duties, which is kind of the opposite of what grandparenting really should be. Right, yeah. But I love that. So you and I know that I believe that exercise is the one thing that reduces all-cause mortality. I learned that again from my father. He exercised 5 days a week.
Oh, that's interesting.
Yeah, so he never weighed more than 150 pounds, 5'10". So
wow.
So
I haven't seen 150 pounds in a long time. Yeah.
So I wake up every morning early enough to do at least half an hour of exercise, a little bit of mindfulness, some yoga. Get to work at 6, and then I always say I have to stay fit because, as you know, I have some interesting hobbies, and one of which is I drive vintage race cars, and we have a lot of fun, and there's nothing like having your life on the line to make you widen your field of view, and your self-preservation needs you to be fit and mentally alert.
Your passion, exuberance, your mindfulness shines through. We are absolutely blessed to have you as our Chief of Surgery, both here at St. Francis and for Catholic Health in general. And I personally look forward to many years of amazing growth and development of surgical services and beyond, cancer services here at Catholic Health.
Well, I could not say that I'm more happy than I am to be part of your team. I feel your passion, and we share that. And I'm sure this conversation sort of undermines or underscores our sincerity to this. And I appreciate being interviewed by you.
Well, thank you for taking the time, and it's been a pleasure to do it here in this incredible, brand new physician lounge here at St. Francis. So thank you for having me.